Tonight's faculty speaker is the medical director of the Hepatitis B Foundation. He is a professor of medicine at the Loma Linda University Medical School and the UCSD Skaggs School of Pharmaceutical Sciences. And he's also worked closely with the University of Nevada School of Medicine in Las Vegas. He has served on the editorial boards of the American Journal of Gastroenterology, Hepatology, and Digestive Diseases and Sciences, among many others. He is the principal at Robert G. Gish Consultants, LLC. Ladies and gentlemen, Dr. Robert Gish.
Kent, thank you so much. I want to extend my thanks also to your team for helping me put this presentation together. Good evening, everybody. Thank you for joining us for this presentation on non-invasive testings and NASH. But what we're going to teach you tonight, and this will be interactive at the end for Q&A, is how to use non-invasive testing across many of your different liver disease diagnoses. I'm honored to be able to work in California and Nevada at multiple locations. I work at a federal clinic in San Diego, La Maestra, and I see Yanis is on, who's one of our great team members, a nurse that works with our team. I have an office in Las Vegas, connected with Loma Linda. I'm also in Fresno, Sacramento and Folsom, Santa Rosa and San Jose, and I have some other new sites that hopefully will be up and running soon. A lot of this is by telemedicine, so these non-invasive tests really help me a lot. And wherever possible, we institute what I call one of our vital signs, which is elastography, with FibroScan really being in the lead for that technology. Let's see if I can get my slides to go forward. I do have some disclosures that are relevant to the NASH world. I'd like to remind you that liver enzymes are different than liver function tests. Back when we were trained, many of us just put everything together calling liver function tests and mixed and matched, but AST, ALT, alkaline phosphatase, and GGT are not liver function tests. These are part of a liver panel, liver enzymes, liver biochemistries. Under the liver function test umbrella is albumin, bilirubin, and really best is the direct bilirubin, and then INR, a coagulation test. Platelets, which we're going to talk about a lot today, are not liver function tests, but they're a marker of portal hypertension. And they're a little bit related to liver function because thrombopoietin is made by the liver and can affect platelet levels. But really, platelets are a sign of fibrosis, portal hypertension, spleen size. Then non-invasive tests could be single or multiple. And they more stage disease, but they're also used for grading disease. This is very relevant for the last year with the coronavirus pandemic, COVID-19, SARS-CoV-2. You need to know your patient's liver status, liver fibrosis, and liver function, and talk about managing those patients with advanced liver disease differently, more carefully. There is a risk for more aggressive coronavirus in those patients, higher fatality rate, especially in decompensated disease, especially in liver cancer patients, but there are trends in patients with cirrhosis. We'll be talking about terminology, simultaneous versus sequential use of non-invasive testing. We're going to have a case. We'll talk about FibroScan, elastography, a little bit on finance, and start pulling all these together to make your life simple. There's going to be a lot of data here, but I'm going to try to keep the message simple at multiple points so you have some really good take-home messages. There's a new term that's emerging called MAFLD, metabolic associated fatty liver disease. This is being used extensively in Asia and Australia. It's starting to come into use a little bit more in Europe. The US is resisting change, which sometimes we do. When we change from primary biliary cirrhosis to primary biliary cholangitis, I remember some very prominent people taking a negative position on that name change, but we sold everybody on the name change, and I think we'll be able to make this MAFLD a better term because we want to get alcohol out of the picture and then reintroduce alcohol really is a separate or overlapping issue. Steatosis is fatty change. NASH brings in the word hepatitis or inflammation. ASH, alcohol-induced steatohepatitis, alcohol use disorder, alcoholic hepatitis. These are all important terms to be thinking about, taking a full alcohol history on your NASH. Now we'll call NAFLD patients. And then there's CASH and MASH, which is combined or both alcohol and non-alcohol steatohepatitis. This is a continuum. We used to call a lot of liver disease cryptogenic, but in retrospect, 30, 40, 50 years ago, we had a lot of metabolic associated liver disease, but the obesity epidemic really took off in the 1990s. And this fat and lipotoxicity are now terms that we need to be thinking about in our patients. The claim is these are asymptomatic diseases, asymptomatic family, but I don't believe that for a moment. I think patients with fatty liver have an inflammatory disorder, are fatigued, have muscle aches and pains, have cognitive changes, have sleep disorders. It's all about you and I taking a better history, being more sensitive to our patients. A long time ago, a decade ago, we claimed hepatitis C was an asymptomatic disease. How wrong we were about that. We learned so much about how hepatitis C is a systemic disease, an inflammatory disease, and fatty liver, very similar. We pick up fatty liver, NASH, NAFLD, through non-invasive testing incidentally, such as ultrasound or CT or MR or a big liver. Statin monitoring. Statins used to be the bad person, the bad boy, bad person, I guess is the correct way to say it now. But statins we now know are liver protective, but a lot of people had liver tests done when they were going on statins or after they'd been on statins. And it was really the fatty liver, the NASH, the MASLD, that was what was causing the elevated liver test. Statins are actually liver protective. Laboratory reviews take place in hypertension and diabetes clinic, endocrine clinic, lipid clinics, health insurance, medical insurance, occupational check, and annual physicals pick up liver disease, often now by more sensitive assessments of AST and ALT. Well, globally, this is a problem. This is, of course, has a lot of countries grayed out, but it's just telling you that Europe, South America, Southeast Asia, Australia, we have huge problems with fatty liver, NAFLD. This is talking about calorie intake. US leads the world over 3,600 kcals per day average. Why we have a little less fatty liver here than, say, Saudi Arabia, which has a little bit lower calorie intake, but more fatty liver, has to do with activity. So Americans still are staying pretty active. In other parts of the world, there's much lower activity and exercise levels. So when you think that somebody has NAFLD, fatty liver disease, assess for diabetes, look at their BMI. If they're Asian, the BMI really should be 22. And an AST threshold for assessing patients really should be 20 or 25. Not what the lab might tell you at 35 or 40 or 45 or 50. Investigations, make sure all of your suspected fatty liver patients have negative hepatitis B and C serology or hepatitis B vaccinated. You really don't need to do an autoantibody workup on every patient, but what your eyes can go to is what are the globulins? If the globulins are elevated, think about an autoimmune workup. And if the liver enzymes are over 150, you really need to be thinking about autoimmune. Celiac disease can present with elevated liver tests, and other diseases, iron, alpha-1, copper, are workups that you can consider. Liver and ultrasound might be the beginning, might be part of the major workup. Every patient I see with elevated liver tests gets a full abdominal ultrasound. I measure the spleen size. I measure the portal vein diameter. We'll get back to the alcohol in a moment. So who's going to benefit from further testing? Basically anybody who has elevated liver enzymes or anybody where you pick up fatty liver on imaging. Those are two major intake points. You can do these NASH scores or fibrosis scores because we used to do liver biopsies on everybody, but in my opinion, you don't need to do biopsies to diagnose NASH. If you have a patient who's got metabolic syndrome, abnormal imaging, abnormal liver tests, and evidence of F2 fibrosis or more, you have the diagnosis of NASH. Again, you're going to tease out how much alcohol might be influencing that, but it's the fibrosis score that signals you've got significant inflammation because you've got significant fibrosis. A little bit more on biopsy. This is what fat looks like. There's inflammation, there's ballooning, and fibrosis. And the fibrosis pattern tends to be this chicken wire type pattern. It can be portal based as well. Some patients with fatty liver on biopsy look like they have autoimmune, but you treat the fatty liver and the autoimmune picture disappears. So this takes a little bit of finesse to figure out if there's an autoimmune component overlapping with the fatty liver. Alcohol is more by history. The AST to ALT ratio helps you a little bit if they've got early fibrosis. Once they have significant fibrosis, any patient can have an AST to ALT inversion. That's proportional to fibrosis at that point more than alcohol exposure. This is fibrosis stage predicting outcomes. Moderate, advanced, and cirrhosis. This is hazard ratio for adverse events, liver cancer, variceal bleeding, ascites, and liver failure. So you need to know in every patient, what is that stage? High risk features. Age comes in because the longer you have been obese, the higher the risk. Diabetes is a trigger. Obesity, especially truncal obesity. One of the vital signs in our clinic before, when we were face-to-face, of course, was getting waist circumference. And we'll be going back to that hopefully in the next 6 months where we can actually get a waist circumference because there's something called lean NASH where the BMI might be in the 22 to 24 range for an Asian or 24 to 26 for a Caucasian. But if they have this truncal obesity, this abdominal adiposity, much higher risk of having fatty liver and having NASH, inflammation, fibrosis. Enzymes can be normal, but remember we're using this new threshold, greater than 35 in men, greater than 25 in women. But I look at an AST and ALT over 20 in general as a flag to assess, over 30 in general as a flag to work up those patients. But these are not sensitive for NASH, NAFLD. You have to look at the enzymes and then you start doing your other non-invasive testing. It's a signal to do further workup. NAFLD grade and stage is similar with normal versus abnormal liver enzymes. But this is a little bit more back in the days when people were thinking enzymes of 35, 40, 45 were normal. So you really have to look at enzymes as time to work up. Then you move to your family, your library of non-invasive testing. AST and fibrosis stage is showing below, but what I want your eyes to go to is the line below the AST. That's the AST to ALT ratio. Somebody with just fatty liver, you're working around 0.6 or 0.7. Once you start getting fibrosis, you hit that 0.8. Once you get 3, 4, you're over 1. So it's free. You look at the AST to ALT ratio. You look at the platelet count. It gives you a good starting point on where that patient is. Then you move into a refinement of your assessment by doing simultaneous or better yet, sequential testing. The real world setting, you're much more likely to be doing sequential. I'm spoiled at my federal clinic where I work in San Diego because Eunice and her team put this panel of labs together for me, and I've got 7 tests when I start assessing that patient. In the real world, when you're in a primary clinic, the numbers are flowing in sequentially as you do a little bit more workup to refine an accurate assessment of their fibrosis status. This has to do with LAC's positive predictive value, predict NASH and fibrosis. This is just summarizing those numbers. The AST to ALT ratio is quite good. Liver biopsy, I'm not going to talk too much about biopsy because we're rarely biopsying our patients. I mentioned the AST and ALT over 150, very likely to get a biopsy to find out what else is going on. And the thing I'm looking for the most is autoimmune liver disease. But when you refer a patient to one of the research centers, which there's many in Southern California, for looking at fatty liver, it's very likely your patients are going to get a biopsy because the FDA still requires biopsies for many of the phase 2B studies, but most of the phase 3 studies, say all the phase 3 studies, biopsies are part of assessing the new drug efficacy. So 4 tests right away: AST to ALT ratio, platelet count. You can go online and do this NAFLD score, and online you can get an APRI or FIB4. FIB4 I like a little bit better than APRI, but you could have a debate on which of those 2 non-invasive tests are going to bring that indeterminate zone down a little bit. What else do we have? We have FibroSure and FibroTest. There's another test that just came on the market called Liver Fast, a little bit different than what we'll talk about with the FAST test with FibroScan. But the Liver Fast test has 7 biomarkers and then includes age and gender into that formula. ELF has been approved by CLIA, I believe, in California, but I haven't seen it commercialized. Supposedly it's available in the US. As we mentioned before, you've got FIB4, the NAFLD score, and NFS score, and APRI at your fingertips. I rarely use FibroSure and FibroTest because I find these are overly sensitive to inflammation. You overestimate fibrosis with higher liver enzymes. Although I do get GGT on all my patients, I think GGT is a great liver test. It also has a correlation with cardiac outcomes. Quite interesting because liver inflammation influences cardiovascular risk, and GGT is very sensitive. It's interesting that Medicare took GGT out of the liver panel, chem panel, back in 1992. Their assessment was they were overdiagnosing liver disease. We were doing too many subsequent testing. But I think because GGT got pulled out, we missed fatty liver for probably a decade until some really good hepatologists like Bruce Bacon and others started bringing fatty liver back into the forefront of our assessment. Now it's really half of a hepatologist practice. You have demographics, you have imaging, you have elastography, and you have labs that we can put together. You know, when you do a NAFLD fibrosis score in FIB4 here, you still have this large indeterminate zone. Quarter of patients, you have no idea what's going on. And the accuracy in the no fibrosis or the advanced fibrosis still isn't quite what you want. And that's why we're talking about doing sequential testing, taking really down to 4 or 5 tests in each of your patients to get down to a very high accuracy. I want to be 97% sure whether they're an F4 or an F3 or an F0 or an F1. I really want that level of refinement. Now back to ultrasound, I just want to take home 12-12. Spleen over 12 centimeters, portal vein over 12 millimeters. That's portal hypertension. That's F4. They need an endoscopy. They need to start liver cancer surveillance. And that spleen size and portal vein diameter is available on any ultrasound. You just have to ask your radiologist to take 4 seconds to measure these things. Now we're going to talk a little bit more about transient elastography. Elastography in general is measuring liver stiffness. There's at least 4 major types of elastography. I'm going to say from VCTE, vibration controlled transient elastography, which was the first form of elastography that moved into the liver world, all the way to MR elastography, which has got very expensive equipment, requires sophisticated assessment of your data output. And with VCTE, you're going to refine your fibrosis assessment even further and get down to that, what I like to call 97% sure where they are on F0 to F4. So landmark publication, basically pulling together in a meta-analysis that it performs well in significant fibrosis and cirrhosis. So there's a lot of data on here. This AROC really is a way I sort of think about accuracy. So you're up in the 90% range, which is really amazing. So some magic numbers on here, 7.25, you're in F3 or F2 to F3 or higher. If you're over 12.4, that person's cirrhotic. Now, there's slightly different numbers for autoimmune, for hepatitis C. So really 11.5 to 14 is that cutoff for cirrhosis. And once you get up to 20 or 25 or 30, that person's got really severe and advanced fibrosis. So you can still keep looking at that number even up into the 40 range or higher. So then we had some comments to EchoSens as we were using VCTE that we needed 2 more pieces of information. We really needed to know how much fat was in the liver. So they came out with what this is called a controlled attenuation parameter. This is how much sound really slows down. And you can see on the right side in the box with the blue letters, the units up above that is decibels per meter. You're really measuring this sound wave. Then elastography also has to do with that speed, and it comes back to the computer, and that's called kilopascals. That's either how stiff or how flexible the liver is. Then you got an AST. Now look at this person. It's got an AST of 213. This person's got a high AST, and I'm going to be thinking about autoimmune, or maybe they're exercising or something else, because that AST that high is quite unusual in fatty liver. But you can put together all 3 of these and come up with what's called a FAST test, which goes from 0 to 1. And it's going to give you an accurate assessment about that fibrosis. Again, you're not going to look at any one of these tests alone. You're going to go through your own brain, artificial intelligence, but our brains are real intelligence, of course. And you're going to process that information to say, let's say the platelet counts 300,000, the spleen is 8 centimeters, but you come up with a really high kPa value. You're going to go back and say, maybe they have volume overload, maybe they're jaundiced, maybe they just had a meal. You say there's something not fitting with this. So you have 6 or 7 tests, 1 or 2 don't fit, you throw them out, and you take the other tests that are congruent. That's how our brain really works anyway when we're assessing our complex medicine patients. So this is what's nice about the FAST score is you bring in inflammation, you have a steatosis assessment, and then you have damage or fibrosis. So you can look at the FAST as a single test, but you really want to look at the components of this as well to make sure you're making the proper assessment. This has to do with AROC, performance. This comes back to accuracy. Again, we're staying up in that 80 to 90 range. This is very, very nicely externally validated. Look at all these different studies that are on here. And then there's a pooled external patient cohort. This is a very, very elaborate paper. I had to look at it 3 or 4 times. It's got 10 or 15 pages of supplements that went into this. This is a very, very sophisticated process. This is a little bit more in the FAST performance. This is looking at FAST versus FIB4 versus NFS and looking across these. So your FAST test is in blue. And you can see in most countries, really except Turkey, the FAST test is outperforming the FIB4 and the NFS score. So really, you can put this FAST, it's free. If you have a FibroScan, you're calculating the cap, you plug in the AST value, it's going to give you these very nice numbers to improve your assessment. So this has to do with ruling in or ruling out with these different cutoffs. So you got a negative predictive value. If you've got a low FAST score that's 85% accurate. Rule in, positive predictive value, 83, if that FAST score is over 0.67. So 0 to 1 is your scale. Gray zone is still there. All these tests have a gray zone, but it's about putting them together to take that gray zone down to a very small number. Here, the gray zone in the US was only 16%, and overall about 30% as you look across all this data. So this is NIT accuracy, non-invasive test accuracy, sort of an overview. This came from the Regenerate study. Regenerate study is using obeticholic acid, and it looks across these different parameters. But let's go back to the negative predictive value. The two tests that were 90 or above were the VCTE, the FibroScan test, and an ELF, which is a blood test, which we don't have available to us anymore. So very, very good data. And again, this is looking at individual tests, what they are, but we're always putting these together. Very high negative predictive value make you secure when you say people have minimal liver disease. That's very nice. This goes across indeterminate findings with any single test. And this assessment, Regenerate transient elastography, had the lowest percent of indeterminate findings, and ELF had the highest at 60%. It's really trying to narrow down indeterminate with a single test, or I'm trying to get indeterminate down to 3%. So you're not ever going to have only one non-invasive test, but what this slide really could say is that you've got these baseline 4 that we talked about. You can calculate, they're free, but if you're going to add another non-invasive test, transient elastography is a fantastic way to refine your patient assessment. So should we do tests all at the same time, like I do? But remember, I'm doing over 7 tests at the same time. Most people are looking at 3 or 4. This is simultaneous accuracy. Looks quite good as you look across all these. As you take NSF plus ELF, FIB4 plus ELF. Here you have NSF plus VCTE in gray, because that's directly available, or FIB4 plus VCTE. Quite nice. You're getting this up into the 90% range, except for the far right is what we're missing, positive predictive value. No real adequate tests in this study, this dual combination for positive predictive value. The simultaneous tests are good for negative, but not that great for positive predictive value. What about doing in sequence? You're going to do a test, then another test, then another test, and move down the line. One of the ways to think about this is to get that indeterminate down, and you're taking this down to less than 20% with just 2 sequential non-invasive tests in here. Sequential is what we're going to be doing a lot in the real world, in real practice. Here's a little bit more on sequential testing. The first test is indeterminate. Specificity is good, meaning you've got a very low false positive rate, 10% or less. Still having some challenges with a positive predictive value. This is what I found very, very interesting, is what was the percent of indeterminate findings. And you see with VCTE, with just one other test, you're now down in where I'm considering it great, which is 5% or less. So in the clinic, you're going to do your basic 4. Thinking about adding a 5th test, elastography should be one of those considerations. Obviously, you've got others. This ELF test may be available as a blood test soon. The liver fast test I mentioned before is already available throughout the United States. It's CLIA approved and CMS reimbursed. So combination sequential tests of good negative, all combination sequential of acceptable positive predictive value. I still like the number to be better. What's really good is indeterminate findings are very, very low. This is a FAST score performance, FIB4 and NFS that's here. FAST is in blue, so it's really exceeding every place again except Turkey. All right, we have a patient here, 45-year-old woman, presents with an abnormal ultrasound. This could be called bright or heterogeneous, or the radiologist could say, consider liver disease, consider cirrhosis. So on ultrasound, we looked a little bit closer, did show fatty liver, the spleen was healthy, portal vein, a little generous, but not quite at 12. Gallbladder had a thick wall, but no stones, probably just an inflammatory finding. But let's take a look at this. The AST is slightly higher than the ALT. Platelets are under 170,000. Those are two things that are pointing towards F3 or maybe early F4. Now the total bilirubin is high, 1.5. I'm thinking, oh my gosh, there's liver failure. but the direct is healthy, really good at 0.2. Albumin, great, 4. INR normal, 1. This person has normal liver function, but I'm thinking F3, maybe early F4. Diabetes workup, elevated blood sugar, hemoglobin A1C, hypercholesterolemia, hypertriglyceridemia, so multiple signs of metabolic syndrome here. GGT, normal healthy GGT is less than 35. This is 60. ALK-PHOS, your lab's going to tell you 115 is normal for an ALK-PHOS, but a paper we just got published really is probably going to reset ALK-PHOS healthy to about 85. Alpha-fetoprotein doesn't really help you in fatty liver directly, but indirectly, AFP plus, AFPL3, and DCP, these are 3 liver cancer biomarkers, tell you risk for having cancer now and look at liver cancer out the next 5 years. CAP score is quite high. So how I remember CAP is under 220 is healthy, over 330 is bad. This person's over 330. So they've got a lot of fat in their liver. VCTE is getting up there in that range towards cirrhosis. And the FAST score is just over 0.67. So I'm very comfortable this person's got F3. I'm going to say advanced F3 because of the platelet count and portal vein. Probably not going to go and do an endoscopy on this person. In my clinic in San Diego, our clinic, we do 3 triple liver cancer biomarkers in our F3 fatty liver patients. And we use that GALAD score, G-A-L-A-D, which uses these 3 biomarkers, plus gender and age, and decide if we're going to start cancer surveillance in our F3. As you know, F3 NASH, F3 MAFLD has an increased risk of liver cancer, but we're not sure when to start surveillance. Well, with this GALAD score, I feel comfortable saying I'm going to start or I'm going to defer or delay. Make sure the patient's vaccinated for A and B. Make sure they're hepatitis C negative, and do a reasonably good alcohol assessment in your patients. One of the recent tests that became available is called PETH, P-E-T-H. That's a way to look back 6 weeks at how much alcohol your patient has consumed, because a random alcohol tox screen might be negative. So F3, talk about what those numbers, and the FAST score is going to push you in that F3 plus range. So here we've got a Jane Doe, we've got biomarkers, we've got a high CAP, we've got elastography of 10.7, we've got a FAST. This is what the output from the FibroScan is. And the physician, Kent Cox, that's over there, is actually the wonderful supporter of this event tonight. Help me put all these slides together. Thanks, Kent. A little bit more an interpretation coming off the FibroScan. It's going to give you a steatosis grade and fibrosis stage. So I think this is quite useful and it's, again, part of that integrated data that you're going to look at in your patient. So as we're wrapping up our presentation, there's going to be a lot of new medicines approved. Obeticholic acid is on hold with the FDA, but I'm optimistic that it will be approved. But when obeticholic acid gets approved, I say hopefully, it's going to probably have a label for F2 and F3 because their reverse study, which is the study in cirrhosis patients, is still ongoing. And they're being very careful about balancing risk and benefit, safety. Look at all these targets that we're looking at with these different medications. That's amazing. Wrapping things up, let's talk about economics just for a second. So patient visit fee and reimbursement is quite interesting because it's a little bit different with Medicare and Medi-Cal than it is with insurance, and it's different in the federal clinic. So the federal clinics, as just a very, very general outline, get paid per patient contact. That could be in the $80 to $250 range. But let's just take an example. Per patient contact, they come in for FibroScan, the clinic gets a $200 reimbursement or payment. And then they come in for their liver consult, they get another $200 reimbursement. So $400 helps support the equipment, the staff, the operations, your clinic space, your electronic health record. So This, in the federal clinic, these finances look balanced to me. It's a little bit more of a challenge if you're working in a Medicare or Medi-Cal where the reimbursement per scan is only in the $47 range. So it's a little bit low. So this is just stacks up what those numbers are. And of course, we're bringing our patients back with contacts monthly for 3 months after our original consult. And they also come in to see a nutritionist and a health advice group that helps them talk about lifestyle changes in general. So you can bring in, with a FibroScan plus a NASH program, a good financial support to help support the equipment reimbursement. Now the cost is the $120,000 range, but of course there's other ways to get FibroScans through lease arrangements as well. So you can pay off these machines if you have significant volume. So take a look at your volume model. So we do have accurate non-invasive tests. They are strongly needed, but we have them in front of us today. And we've had the addition of this FAST test, which is part of that FibroScan output. And we have a new liver fast blood test that's on the market and available. And there'll be more information about that blood test soon. So you've got challenges with any single test, but Sequential, great for primary care, or Simultaneous, which I'm honored by a lot of the clinics where I work, and maximize your use. Make sure you get a full abdominal ultrasound. You look at liver function. And you're going to be tracking these patients. Every 1 to 3 years, we do our follow-up elastography.